Start. Good morning, everyone. I'm Dr. Govind Tiwari, Assistant Professor of Cardiology in UN Mehta. Today, I'll be presenting hypertrophic cardiomyopathy management. So, when we have to manage HCM, we have to look for indications for therapy. Main therapy indication is symptoms. So, if symptoms are not there, then you can give a patient a therapy of no trial. If symptoms are present, then we have to establish whether there is obstruction or no obstruction. For obstruction, we have to see for the exacerbating factors, that is volume depletion. So if patient is dehydrated, or if we have to check for medical history, if the patient is taking any ACE, ARB nitrates, phosphodiesterase inhibitors, that can lead to vasodilation and hypotension. And in hypotension, the cavity shrinks, the alveolar obstruction increases. After this, we decide a medical therapy, that is beta blocker, whether that is a first line, or calcium channel blockers, or plus or minus disopyramide. Similarly, if the patient is having no obstruction, we'll start with a medical therapy, that is beta blocker, calcium channel blockers. If patient is having symptoms of congestion, then we have to go for a low dose diuretics. Even if the patient is having refractory symptoms and there's a low EF, we have to go for advanced heart failure management. If patient is having similar restrictive physiology with the hypertrophic physiology, then we have to go for a cardiac transplantation and becomes difficult to treat. So how much obstruction is important? Obstructive HCM peak gradient of more than 30 mmHg is considered significant. More than 50 mmHg is sufficient to cause symptoms. And you have to believe that it's a dynamic gradient. If there's a decrease in systemic vascular resistance, decrease volume, increase heart rate, increase in force of contraction, so there will be dynamicity of the gradient. In echo, we have to ask the patient to do a Valsalva maneuver or do some exercise testing or treadmill testing or do sit-ups and provoke a gradient. Every time you see a patient of HCM, always try to provoke a gradient because it's a dynamic. So initial medical therapy for symptomatic obstructive HCM. First line approach and drug selection. First line therapy is beta blockers. Initial step for LVOT obstruction, preferred over CCBs and other agents. Use non-vasodilating beta blocker as we don't want hypotension in patients of HOCM. Start metoprolol 25 mg daily. Maximum dose can be going up to 200 mg. Titrate as tolerated. Typical dosing is to increment the doses every week till resolution of symptoms or till the dose is tolerated. For example, the patient has come to you, has HOCM with LVOT obstruction. You start a beta blocker, for example, metoprolol at 25 mg once daily. Second week, you titrate up to 50. Third week, you titrate up to 75. Fourth week, you titrate up to 100. Till the resolution of symptoms, a patient is not able to tolerate beta blocker. We'll see what happens when the patient is not able to tolerate beta blocker. If beta blockers are not tolerated or if ineffective, switch to extended release verapamil or diltiazem. We have switched over to calcium channel blockers. Starting dose is 120 to 180 mg daily. Titrate up to 480 mg daily. Consider diltiazem ER as an alternative with the same dosage. So doses of both the medications are same. But we have to be cautious with verapamil. Verapamil, the possible side effects are sinus arrest, A block, has more vasodilatory property because hypertension. So avoid in patients who are having hypotension, have volume overload or severe obstruction, as verapamil may be detrimental for those patients. Management of symptoms that are refractory in obstructive HCM. Summary of additional medical therapy and septal reduction options. Treatment pathways. When the patient is having refractory symptoms, we can add an additional medical therapy or we can go for an invasive thing, that is septal reduction therapy, that is algoseptal ablation or surgical myomectomy. Choice is based on patient preference and center experience. So additional medical therapy options are disopyramide plus beta blocker or calcium channel blocker, myosin inhibitors, that is mavacamten, aficamten plus beta blockers and CCBs. Choice depends on center experience, monitoring ability, side effects, and the patient profile. The affordability as well has to be considered while making the choice. So disopyramide, it's a negative inotrope, has class 1 antiarrhythmic action, used when symptoms persist despite beta blocker and calcium channel blockers, must be combined with AV nodal blocker, increases AV nodal conduction. A patient with HCM has AF and you give a disopyramide alone, then patient has high chances that the AF may convert into VF. So it has to be always combined with an AV nodal blocker, not to be given as a sole therapy. Requires QTC monitoring. Initial dosage is 200 to 250 mg twice daily. If symptoms do not improve, increase by 100 mg per day at 2 weeks interval to a maximum dose of 600 mg administered in 2 divided doses. Limitations of disopyramide: QTC prolongation increases torsades risk Avoid with amiodarone, sotalol, class 1 agents. Anticoagulant side effects are common like dry mouth. Avoid in patients having BPH and open angle glaucoma as it may further exacerbate these conditions. Myocontin, inhibitor of cardiac myosin activase inhibitor. So this is a structure of sarcomere. This is a normal sarcomere. As you can see, there is actin thin filament, actin myosin cross bridges, myosin thick filament. Myocontin is a targeted inhibitor of cardiac myosin that reduces the number of myosin actin cross bridges and decreases contractility. So it reduces the number of myosin actin cross bridges and it decreases the contractility. So myocontin acting on this sarcomere unit, it leads to attenuated hypercontractility, improved compliance, and improved energetics. There were 2 trials for myocontin that are the landmark trials. One is Explorer HCM trials. So Explorer HCM trial, myocontin for treatment of symptomatic obstruction of hypertrophic cardiomyopathy. It was a randomized double-blind placebo-controlled phase 3 trial. Now, looking at the primary endpoints, what myocontin is helping in patients with HOCM, that increasing the partial pressure of venous oxygen, that is more than 1.5 ml per kg per minute, with more than 1 NYHA class improvement. Or there is more than 3 ml per kg minute per increase in PVO2 with no worsening of NYHA class. So you can see in the data that myocontin versus placebo, myocontin is significantly helping patients with HOCM to increase the functional capacity of the patient. And the secondary endpoints were decreased NT-proBNP, improved KCQQ score, increased E' velocity, decrease LV mass, decrease LA volume, and decrease E by E prime. So what it does, it helps in diastolic dysfunction as well, decreases the NT-proBNP, and increases functional capacity. So this is what myocontin is helping. This was a primary endpoint for the patients in Explorer HCM. But as properly the contrary belief, there is slight decrease in EF, that is EF decreases of around average around 5%. It though contraindicated in patients who have EF less than 50% and still can be safely used. For EF, you have to follow up patients every 4 weekly. If you are starting myocontin, you check ego after 4 weeks, then 8, then 12, and look for reduction in LVF. If LVF reduces to less than 50, then we have to stop myocontin. As you can see in this chart, this large decrease in LVOT gradient, a mean of 40 mm of Hg LVOT has decreased after starting myocontin. So there was another trial, Valor HCM, that was evaluation of myocontin in adults with symptomatic obstructive HOCM who are eligible for septal reduction therapy. It drastically reduced the patients who are undergoing septal reduction therapy, so was beneficial in them as well. Interventions in HOCM. So choice of invasive septal reduction therapy. Indications are patients who are having medically refractory symptoms, gradient more than 50 mm of Hg, resting or provoked. So myomectomy versus ablation. Patients having extensive LVH, intrinsic mitral valve disease, surgical CAD, have to favor undergo myomectomy because extensive LVH, you can't alcohol septal ablate the entire LVH thickness. Intrinsic mitral valve disease requires concomitant mitral valve surgery. Surgical CAD requires a bypass grafting. Factors favoring ablations are comorbidities and increased surgical risks. Patients who are having obese, elderly, and are increased surgical risk, you prefer alcohol septal ablation. Patient preference. Nobody wants to go under a scar and open heart surgery, so patient preference is also considered as an important point. And suitable cardiac coronary anatomy. So a septal perforator has to supply a basal septum for successful alcoseptal ablation. And lastly, available expertise. If your center is much more better doing septal ablation rather than myomectomy, you go for septal ablation. Alcoseptal ablation. First step, perform a standard coronary angiography to define coronary anatomy and concomitant atherosclerotic disease. Aerocranial or posterior anterior cranial view projections is used to visualize septal artery coursing through the basal interventricular septum. Second step, a temporary pacemaker should be placed as a prophylactic measure in case of development of CHB. Heparin administered to keep ACT more than 300 to prevent thrombosis in the guiding catheters or wires. Temporary pacemaker placement. The risk of pacemaker dependency from septal ablation varies according to baseline ECG abnormalities. Septal ablation frequency results in right bundle branch block, approximately 50% of cases. Thus, for patients with left bundle branch block, severe left axis deviation, or very wide QRS, the rate of pacemaker dependency is 50%. However, permanent pacemaker dependency from complete AV block still occurs in 5 to 10% of patients with normal ECG. Third step, a guiding catheter is chosen, 6 French or 7 French catheter used to engage the left main. A 0.014-inch guide wire with a soft tip is passed into a selector septal perforator. A short over-the-wire balloon angioplasty, usually 1.5 to 2 mm in diameter, is passed over the guide wire into the selector septal branch. Balloon is inflated to completely occlude the septal branch to prevent any reflux of injected alcohol. It may cause adverse effects in the patient. So as you can see here, we define the coronary anatomy. This is the first septal that is going into the basal interventricular septum. This is the LAD. The guiding catheter has been over there. You pass a 0.014-inch wire over here, and then over the wire balloon is inflated, and the contrast is injected over here. Make sure the contrast doesn't reflux into rest of the coronary systems.
Right.
Fourth step, we have to verify myocardial territory being supplied by the selected perforator. Given a significant variation in septal anatomy in its same patients, both angiographic as well as echocardic confirmation must be obtained prior to proceeding with alcohol septal ablation. So, angiographic confirmation, 1 to 2 cc of contrast is administered over the wire balloon. 3 things to be observed. Ensure that the selected perforator supplies the basal septum, that is responsible for LVOT obstruction. Contrast does not reflect back into the LAD. Contrast shouldn't reach RC circulation to septal collaterals. So this you have to keep things in mind. Before injecting alcohol, you have to keep these things in mind, otherwise you can cause complications. Echocardic confirmation is second. After careful visualizing the septum in a apical 4-chamber view, lax view, 1 to 2 cc of albumix, 20% albumin is injected into the septal perforator through the over-the-wire balloon. Appearance of echocontrast should be visible at the greatest extent of septal mitral contact. Appearance of contrast in distal septum, right ventricle, or other areas of myocardium is a contraindication to ethanol infusion. So contrast should be particularly limited to the area of your interest. Shouldn't go here and there. So this is a diagram showing the same. Echocardiographic images in the apical 4-chamber view before and after injection of echocontrast through the lumen of the over-the-wire balloon. Increased echo signal is seen in the correct position in the basal septum, that is encircled over here. Myocardial contrast imaging during algoseptal ablation. Echocardiographic images in the plaques view confirms the presence of increased echo signal situated correctly exclusively on the left side of interventricular septum. If you see this kind of picture, then you are good to go ahead with the algoseptal ablation. Final method of confirmation is you inflate the balloon. When you inflate the balloon and there is more than 30% reduction in the LVOT gradient in the selected septal perforator, you means you are doing the right thing. Fifth step is final. Alcohol injection, 1 to 2 ml of 100% ethanol, absolute alcohol over 1 to 5 minutes with balloon remaining inflated. Make sure your alcohol doesn't go into other systems of the coronaries or may cause complications. Final step is angiography of left coronary artery to document occlusion of septal artery and to verify integrity of the rest of the coronary circulation. Post-procedure, monitoring in ICU for at least 48 hours. TPI can be discontinued after 48 hours if there is no bradycardias or heart block. Results: a reduction in LVOT gradient after algoseptal ablation demonstrate a triphasic response. So 3 phases will be there. Active reduction in LVOT gradient. Second phase will be increase in gradient to the baseline levels within 3 days. Third will be decrease in LVOT gradient to immediate post-ablation level within 3 months. So active reduction of LVOT gradient, loss of septal contractility caused by ischemia, necrosis and stenting of septal myocardium. Increase in gradient to baseline levels within 3 days, recovery of septal myocardial from stenting. Third is decrease in LVOT gradient to immediate post-ablation level within 3 months, thinning of infarcted septum and LVOT remodeling leading to sustained and more permanent reduction in the gradients. Successful alcohol septal ablation is reduction in LVOT gradient to less than 30 mm of Hg in the setting of resting gradient or more than 50% reduction in provocable gradient. Complications are ventricular fibrillation, LED dissection, pericardial effusion, CHB, large anterior wall MI, RBVB. 30-day mortality is 1.5% and post 30-day mortality is 0.5%. Second is septal myomectomy. Transaortic septal myomectomy is gold standard for majority of patients with obstructive HCM and severe symptoms refractory to medical therapy. 5 to 15 grams of myocardial tissue is resected from the base of the aortic valve to a region distal to the mitral leaflet such that the area of mitral septal contact that results in SAM is removed. To correctly identify the involved portions of LV septum, you have to take help of transesophageal echocardiography that assists with location of desired region for resection and to monitor effects of resection of LVOT gradient intraoperatively. In real time, you see the basal septum and the resection and how it is relieving the gradient. Patient selection. Severe drug refractory cardiac symptoms, class T4 due to obstructive HCM, dynamic LVOTO, more than 30 mm of Hg at rest or 50 mm of Hg with provocation, that is due to septal hypertrophy and systolic anterior motion of the mitral leaflet. Significant intersect mitral wall disease, need for concomitant surgical procedures. So that's how we select patients for myomectomy. Complications are complete heart block, left bundle branch block, VSR, and mortality. That is less than 1%. So factors to consider while choosing an alcohol septal ablation versus surgical myomectomy is age and arrhythmias. Induction of transmural myocardial scar by alcohol septal ablation can be deadly. It can increase the future risk of ventricular arrhythmias. After alcohol septal ablation should not be performed in patients less than 21 years old and should be discouraged in patients less than 40 years old unless there is contraindication to surgery. Pre-existing bundle branch block myomectomy produces LVB, contraindicated in RBVB. Alcohol septal ablation produces RBVB as we are putting the alcohol in the first septal perforator. So it's contraindicated in LVBB. Anatomy of LVOT, anomalous insertion of papillary muscle into mitral valve, massive hypertrophy, anatomically mitral wall leaflet, valve with a long leaflet. All these favor septal myomectomy. Concomitant cardiac problems such as coronary artery disease, mitral wall disease favors septal myomectomy. So comparing alcohol septal ablation and myomectomy, you can see it's almost similar, except there's a permanent pacemaker implantation is much more required in alcohol septal ablation. Repeat procedure rate is much more required in alcohol septal ablation. Otherwise, both have equivocal results. Emerging therapies. So there's a article published in JACC, that is transcatheter myotomy to reduce LVOT. So this is called Sesame procedure. Transcatheter myotomy to reduce LVOT obstruction in HOCM, a novel non-surgical technique to relieve LVOT obstruction by performing a controlled septal myotomy using a wire-based approach. What Sesame stands for is septal editing by selective architecture, myotomy execution. Minimally invasive alternative myomectomy and alcohol septal ablation. It acts by distorting the architecture of the interventricular septum so that the gradient decreases. It doesn't involve dissection of the myocardium, nor it requires any alcohol to be injected in the myocardium. So key concept is it creates a precise cut across the hypertrophied septum by advancing a stiff guide wire from LVOT to RV. Effects it weakens the septum, reduces SAM septal contact, lowers LVOT gradient. So pre-procedure planning has to be done. This is a CT image of procedure planning for Sesame. What you can see is the green line depicts indented trajectory to be traversed and lacerated. This is an fast view with side projections angle derived from the CT to be used during fluoroscopy. So you have to go for a pre-procedure CT to where you have to transverse the entire myocardium and where you have to lacerate, and you have to obtain similar images in the fluoroscopy so you can perform the procedure without any problems. Procedure steps is LVOT axis. A catheter is positioned in the LVOT near the SAM septal contact point. A stiff wire is advanced to the septum into RV under intracardiac echography plus fluoroscopic guidance. Controlled myotomy. The operator performs a controlled cutting of septal muscle by repeatedly advancing and withdrawing the wire, similar to creating a cheese wire myotomy. Confirmation. This is a real-time image confirmation of myotomy length, reduced SAM septal contact, and reduced LVOT gradient. This is a representative Sesame procedure. As you can see, there is a pigtail catheter in the right sinus of valsalva. Red line marks the medial and lateral position of the guiding catheter as the guiding catheter is abutting the basal septum. There is a dashed red line depicts a trajectory of the intramyocardial guide wire navigation. The pigtail is relocated to the apex. The guide wire is snared once it enters the left ventricular cavity. A flying V laceration surface is positioned at the distal myocardium border. The energized during traction to create myotomy. So the guide wire is snared to the LV cavity and energized during traction to create myotomy. Before lacerating, the T is used to confirm the entry point and depth and length of the guide wire intramyocardial position. So this is how you try to perform a sesame procedure. So there's a schematic of sesame procedure: microcatheter, guide wire, guiding catheter, flying V electrosurgical laceration surface, electrification. Electrification leads to a laceration. So you need a good anatomical understanding of the by fluoroscopy, by computed tomography, and by echocardiography. So you have to take all these three in mind and do the procedure very carefully. Why sesame is important? Avoids risk of alcohol septal ablation, avoids open heart surgery, provides controlled mechanical septal modification, immediate LVOT, gradient reduction. Reported outcomes: high procedure success, significant gradient reduction, symptomatic improvement, low complication, and pacemaker rates. Limitations: requires high operator expertise, the learning curve is there, not suitable for very thick septum or poor LVOT to RV trajectory, and still is emerging and investigational. Thank you very much.